I warmly welcome Professor Kamar Lodi Sahab, who is an ex-head of department at Data Darbar Hospital. He is the chair for this session. May I invite Professor Suhail Sarwar Sahab to join him as the co-chair for this session. Professor Suhail is a former principal of College of Ophthalmology and Allied Vision Sciences, and he was the backbone of the projects that you are going to listen to. I also welcome Professor Hugh Taylor in this session. Sir, with your permission, may I invite the first speaker? The first speaker on this session is Mr. Rizwan. He'll be talking about the CBM Peak project. Rizwan sir.
Thank you very much, Dr. Shahir, Dr. Suhail Saab and Lodi Saab and all the audience. It is my pleasure to speak on the CBM Peak project Chakwal, which is being implemented in 2022, and till now we have a very great success in that. This is a success story, and we would like to share with you guys. This is CUAVS, as you all know, the College of Ophthalmology and Allied Vision Sciences in Mia Hospital, Lahore. These are the two main thumbs for this project, for this success of the community eye care program. The Professor Muin, who is the ultimate lead, and Dr. Zahid Awan as the community ophthalmologist and IEH program manager for the CBM, and obviously me. CBM and CUAVS has a 25 years of partnership of 15 mega projects. This is a CBM Peak project Chakwal from 2022 to 2024. This is the district of Chakwal. This is some demography with the hilly forest areas and green fields and hilly areas in that. And because this is important to know about the Chakwal, because the Chakwal has all type of geographical locations over there. This is the main you can say the assessment of the health facilities over there, what we have in the project with the government and with our NGO support. We are working in 81 health facilities which are connected with peak technology, in which 63 BHUs, basic health units, 13 RHCs, 3 THQs and 1 DHQ. And what is this 1058? 1058 LHWs are connected through the peak technology, along with the 48 school health and nutrition supervisors. So these are our screeners over there who screen the population of Chakwal, the adults and all the school going children. 2 ophthalmologists are present over there, and one we have a specialized healthcare center which is situated in Benazir Bhutto Shaheed Hospital, Rawalpindi, which is TTH for the specialized eye health services. This is the background why we choose the Chakwal for this project, or the national coordinator at that time, Professor Asad, why choose that project. As per WHO suggestions, and inclusive eye health services were not present at that time at primary levels in Chakwal. Chakwal is also very, you may say, the poor area in the North Punjab. Same, the to reduce the refractive burden on THQs and DHQs. Economic burden in the area due to the poverty. And also we need to improve the quality of the life, inclusion of technology into the health systems, and strengthening the existing public health systems. These are the main factors which contribute to have this project in Chakwal. How we implement, there are a lot of things that we have done over there in last 35 months, around 3 years. Kick-off meetings, plannings and health facility assessment, pilot phase. What is the pilot phase? That is, we took one BHU, one RHC and one THQ hospital with ophthalmologist over there and put them on the technology. And with that, we grew up with BHVI optical shop. Optical shop, we are also providing the optical services over there. Nomination of the peak screeners. The cadres who are already working in the government sector, we used those cadres to strengthen the government systems. Just we put the technology in those systems. Hiring of the project staff, obviously the optometrist at the RSCs under this project. Procurements for IUPD procurement, training of the implementing team, core team, field tests, and field test how the project, how the software is running through the project. Live project was on 10th of November 2018. This is the main concept, which is being technologized, put on the technology. Okay, we will have screening, then triage, and then reception, and then provide the optical services. This is the success what we achieved in last 3 years. We have screened 2.8 million people over there in Chakwal. Through LHVs at the BHUs, that is 825,000 around. LHWs door-to-door screening. They have screened 1.8 million, and they are 1009 screeners over there who are using the peak technology on the Android mobile phone and screen and took the visual acuity of the of all the patients or all the population over there. SHNSs, 48 SHNSs, they screened 157,000 children in last 3 years. These are the referred patients by the LHVs, LHWs, SHNSs who need optometry services or the next level services at RHCs. And what is the what is this 78%? 78% is the triage adherence rate. The people who are referred from different communities or schools or door to door, they have at 78% people attended the optometrist. This is the big success that we have achieved in this, and we have calculated and we have monitored this through peak technology or peak capture software or peak admin. There are two phases of this. This is the positive outcome, okay, which patients were referred. From them, 95% referred patients by the LHVs are true positive, means they have the eye condition, some eye condition. Maybe that would be refractive conditions or non-refractive conditions. Same with the 81% are true positive with the LHW's referral, and 77% are the true positives for SHNSs. This is the refraction that we have done in last 3 years, 68,226, in which distance spectacles were 28,000 and near and both and this. And this whole patients, which are the 58% of the true positive patients, will be referred to the community optical shop, which is providing the free near vision glasses of around 12,000. Free for the children 2,000, and then subsidized for the adults, that is around 5,042. Community optical shop is present in the local community over there, and that is also the partner of College of Ophthalmology. This is the reception of the ophthalmologist review. 8,700 people were referred for the ophthalmologist review over there in Chakwal, and 60% of that has attended the ophthalmologist. And these are some project activities, and this is the thing that I need to share with all you guys, that connected to care. This is the new concept in Pakistan, and this is implemented in Chakwal. And in last 35 months, what we have calculated through our different sources, 81% of the people who need eye health services have been connected to care. Thank you.
Any questions from the audience? Thank you, Rizwan. May I invite Professor Hugh Taylor for his talk on global eye care?
Right, thank you very much. It's a great pleasure for me to be in Pakistan again, and I want to talk now about some global eye care, about where we are. And I know we all know a lot and still need to learn more about AMD and diabetic retinopathy, glaucoma and myopia, etc. But the leading cause of vision loss around the world are unoperated cataract and uncorrected refractive error. So I want to talk about those two things in the time that I've been given. Now, in Pakistan, cataract surgery has made a huge improvement in its cataract surgery rate, improved by more than 200% in the last 18 years. So it really has made some really good progress. And if we look globally, there has been improvement in the rates of blindness and moderate and severe vision loss and mild vision loss in each of the 17 regions analysed by the Global Burden of Disease. And you can see the stars indicate where South Asia stands, which includes Pakistan, of course, where there's been tremendous improvements. But if we look at the forecast for the number of people who are going to be blind and have vision loss, they are going to continue to increase as the population grows and as the population ages. So even though the percentage or the percentage rate are decreasing, the numbers are increasing. And you can see that the rates are higher for women, a little bit higher at every age. It's not only that women tend to live longer than men, but they are higher rates all the way through. Now, in 2021, the World Health Assembly put together two measures for the improvement of eye services. One was to increase the effective coverage of refractive error, and the other was the effective coverage of cataract surgery. And by effective cover, they mean the number of people who have got glasses and who have good vision with their glasses, or the number of people who have had cataract surgery so that they have good vision with their cataract surgery. So this is a real challenge, not just doing cataract surgery and having people still with poor vision, but it's doing cataract surgery and making sure people can see well. And we can see that the rates of vision loss and blindness, the highest rates are in, as I said, in cataract and uncorrected refractive error. And if we look at the rates in vision loss from cataract, we can see that the number of people with vision loss, either moderate, severe vision loss or blindness, is increasing dramatically over the last 30 years, but the prevalence rate is remaining similar, but the amount of blindness is dropping. But what's important is the effective cataract surgery coverage rate. That's the number of people who can see 6/12 or better after surgery, and you can see that it's only 17% have got 6/12 or better vision after surgery, and 24.8 or 25% have got vision of 6/18 or better after surgery. So that means 3/4 of the people who've had cataract surgery, vision is still less than 6/18. And you can see that for South Asia or Southeast Asia, the cataract coverage rate is 57%, but the effective cataract surgery coverage rate is 40%. So still more work to do to improve that. So to address effective cataract surgery coverage, one has to focus on improving access, but maintaining or improving quality. We have to focus on the historically underserved populations, those regions where they're hard to get or more remote or poorer regions, and consider support for patient counselling and transport, and if needs be, subsidising for glasses. But it also, so areas on that, but in quality, we've got to look at improvement in the biometry, the IOL assessment, and also in the range of IOLs that are available at the time of surgery, and to make sure that they are available and affordable. For refractive error, we can see a tremendous increase in the number of people who have moderate or severe vision loss from refractive error. And although the prevalence is reducing somewhat, the percentage of people, the number of people who need treatment is dramatically increasing. And again, for the effective coverage rate for refractive error, it drops down by age, so that in the older age groups, it's only 20 or 30% who can see 612 with their glasses, and only about 40% who can see 618 or better with their glasses. And you can see that in Southeast Asia, the effective coverage rate overall is pretty good, much better than Africa, and it's over at about 80%, but still needs further improvement. And again, one has to look at improvement of effective refractive error coverage, issues on access with people, and things like the peak scanning is a great way to get out into the community to improve coverage and to make sure that access is available in the low areas and difficult areas to get to, and to subsidise the provision of glasses to make sure they're there. And one needs to have improvement in quality with government oversight, with clinical regulation, and with standardising and improving the training and making sure when people need new glasses that they know to get tested and to get them. So in summary, there's some really great progress being made globally in reducing the prevalence, the percentage rates of blindness and vision loss. The prevalence of blindness has halved over the last 30 years, but the numbers are still increasing because of the increasing population and the increased ageing of the population. Women still have higher rates of vision loss at every age than men, and this is something that we do need to look at. And the integrated people-centred eye care advocated by WHO shows the way, which with specific challenging goals and accountability. But we must reach everybody, and we must have effective coverage rates. Thank you very much.
Thank you, sir, for your valuable input. Is there any question from the audience? Okay, next talk is on epidemic keratoconjunctivitis by Dr. Shuja Rahman.
Bismillahirrahmanirrahim. Thank you very much, Dr. Shahid. So the topic I'm going to present is epidemic keratoconjunctivitis, the perspectives and management diversification among the ocular health professionals of Pakistan. I am Dr. Shuja Rahman from your hospital, Lahore. So this is a non-disclaimer that this presentation is based on data and findings from a specific study that is conducted among the healthcare professionals. The insights and the conclusion drawn are intended solely for informational and educational purposes. So the objectives of this study, we have two set goals. The first goal was the development of consensus on EKC outbreak management strategies. And the secondary goals were the launching awareness campaigns and establish SOPs to reduce the nosocomial EKC cases. So the introduction, as we all know, that the epidemic keratoconjunctivitis is a common viral inflammation of the conjunctiva and accounts for 80% of acute conjunctivitis cases. The symptoms including eye pain, discharge, redness, chemosis, subconjunctival hemorrhages, fever, and preauricular lymphadenopathy. The causative organism in most of the cases is adenovirus and is specifically serotypes 8, 37, 53, 54, and 64. The characteristics of this virus is non-enveloped, resistant, highly contagious virus. And the mode of transmission includes a direct contact with the ocular secretions or contaminated surfaces. And it affects all age groups, including children, pediatrics, including the old age population, everyone. So the technique that we used was descriptive cross-sectional study That was conducted from November 2023 to January 2024. And data was collected by the Google Forms. We used Google Forms for that, and a set questionnaire that was self-designed, we use it. And the analysis of this data was performed on SPSS 25. So the methods and materials I have already explained, that this is a descriptive cross-sectional study. It was done on the eye department of the Mayo Hospital, Lahore. The duration was 3 months, and the sampling technique that we used for the purpose is sampling. So the gaps in current knowledge, what was the literature gap that we wanted to cover with this study was that the emphasis on the hygiene, but no standardized preventive measures were available. The second thing is the management protocols, absence of consensus on the treatment guidelines. The third thing was the effectiveness, that the limited data on the efficacy of existing preventive strategies and treatment measures. Our aim was to identify the current clinical practices among the healthcare professionals in Pakistan during 2023 EKC outbreak, and the outcome was the development of the effective management and preventive strategies for EKC. The research questionnaire was the main question was, what are the clinical practices in managing EKC in Pakistan? And there were sub-questions that how effective are the existing preventive strategies, and what are the challenges faced by the healthcare professionals by managing the disease. So these were the forms, and 94 responses were included in the inclusion criteria. This is how we collected the data: Google Forms, WhatsApp, email. These were the distribution channels, and the question selection were demographic biodata, diagnostic criteria and symptoms, current management practice, and preventive measures. These were the 4 domains that we cover in this. Then the analysis of the data, including the softwares we use and the variables. This is expressed as frequencies and percentages and the mean standard deviations. So the most important thing of this research were the demographics. In case of physicians, male and female almost equal. Age groups almost 30 to 40. Less than 30 was 28%, and greater than 40 years were 20.2%. The most important thing is professional goals. There were PGRs and the medical officers, they were 52%, and their number was almost 49. The consultants were 42, and the professors there are 3 professors that were included in that. The workplace distribution, they were working as a public sector 45.7%, private sector 19.1%, and both 33.1% means they were doing their private practices and they are working in the public sector too. The cases management, greater than 20%, 10 to 20%, and less than 10% cases, 7.4%. Just diagnosis of the clinical examination, this was 98.9% physicians diagnosed on the clinical basis. And the causative agent that were adenovirus, it was 89.4%. The affected groups were adults, 76.6%, and pediatric population, 23.4%. These can vary because this is a limited research. These domains can vary, but these were our findings. So the clinical features that we encountered were the conjunctival reaction, including follicular, papillary, but the predominated was follicular. Corneal involvement was there in the complicated cases. The diagnostic approaches that we used was clinical acumen. Basically, we diagnosed all the cases of EKC on clinical acumen. 92.6% of the physicians diagnosed this on clinical acumen. PCR tests were done, 7.4% people. And what were the treatment preferences? Mild to moderate EKC, most of the physicians, 46.8%, use antihistamines, lubricants, wash, preventive measures, antibiotic and steroids, 16%, and combination, 37% of physicians use. In severe EKC, there were the aggressive topical therapy, which were used by 71%, 8.5% patients were hospitalized, and the referral was 20.2% at the BHUs and RHCs. The other thing that's the most important thing is patient education and prevention. That the combined isolation protocol, 64.9%. The other thing was public infection control measures. These were just 25.5%. So this thing depicts where we are lacking and where we need reinforcement, that the patient education and prevention, because it's better to prevent a disease. It's good to treat a disease, but it's better to prevent it. So these are the compliance of the patients. These were the results of this research. These are the bilateral ocular involvement, corneal involvement, associated soft tissue eyelid involvement. These are all related to the clinical presentation of this disease. This, as I have explained early. So this is the treatment choices. Steroids. Most of the physicians use the steroids. So the drug of choice that comes out to be was steroids and the combination of the steroids. So this is the net conclusion that comes out to be that the adult population was affected more during this outbreak, and the topical steroids were considered the single most effective drug in the treatment, and the public health measures were considered more crucial in effective management of EKC outbreak by the majority of the ocular health professionals. Thank you very much.
Any questions? Thank you, Dr. Shuja. I'll invite, yes, please.
One very good thing about this, although it's a very epidemic problem, but all the questions were answered in the talk, so there are no questions from the audience. That's very good. Thank you, Dr. Thank you.
Thank you, sir. I'll invite Mr. Shahid Sohail for his talk on barriers in eye care access at rural health centers.
थैंक यू वेरी मच शहीद साहब। शहीद साहब के लिए मैं एक शेर ज़रा कहना चाह रहा हूँ। कोई वीरानी सी वीरानी है, कोई वीरानी सी वीरानी है, इस गुलिस्तान को देख के अपना घर याद आया। थैंक यू सर। तो my name is Shahid Sohail and program officer at the College of Ophthalmology and Allied Vision Sciences. Today I will presenting my presentation on the topic of challenges in accessing eye care in rural health centers and the modalities we have implemented to cater these challenges. These projects are implemented at the College of Ophthalmology and Allied Vision Sciences in collaboration with SightSaver. Here is the outline of my presentation. First, we will explore the challenges to access eye care in rural health centers, and then I will discuss the strategies we have implemented to cater these challenges. Following that, I explain the referral and screening mechanism we have established. Lastly, I will share some key achievements from these interventions. Unrefractive corrective errors are the leading cause of blindness in Pakistan. But these refractive errors are addressed easily with the eye examination and pair of glasses. Estimate 15 million people need visual impairment and refractive surfaces. Following that, I will explain screening, and unfortunately, around the 15 million people have been need refractive errors, and 8 million people need out of them in Punjab. Examination and refraction is the only available in charity and private hospitals. Before this project, there is no services at RIC levels. Only services are available in urban areas, not in the rural areas. The shortage of eye care professionals is a big challenge for us when we started our projects. and this leads to patient time-taking travel, service, limited service availability. Additionally, financial constraints prevent many people from reaching health facilities. Cultural and lack of awareness further discourage people to reach health facilities. Finally, socioeconomic condition of the rural peoples, especially marginalized people, are the main barrier to access the eye care in the health facilities. To address these challenges, we established 32 optometric clinics and provided ophthalmic and non-ophthalmic equipments. We deployed 32 optometrists, 8 green optical shops have been established for the provision of glasses, and almost 9 linkages have been developed for the private optical shops. We have conducted accessibility audit and carried out civil work to each health facility for reaching person with a disability into the health facilities. Human resource is the key focus of our strategy. We engage in advocacy and developed training programs for the various stakeholders, including lady health workers, lady health supervisors, medical officers appointed at BHU, medical technicians, school health and nutrition supervisors. To support these work, we designed and disseminate IEC material like leaflets, brochures, etc. And we utilize the technique of social media and use all means of media. To address screening and the referral mechanism, our screening and referral mechanism have multiple levels to ensure comprehensive eye care. Community levels, lady health workers address screening during her door-to-door visits, while school health and nutrition supervisors focus on screening in schools. At BHU level, medical officers and medical technicians identify the refractive errors, and all those refer to the optometric clinic, where our optometrists provide optical services for those who need further advanced eye care. Then refer to the THQ and DHQ, and for the subsidized glasses, patient refer to the green optical shop. There are some results we show here. Our interventions have had a significant impact. You can see the numbers, number of examination, refraction, patient advised spectacles, refer to the next health facilities, persons with disabilities, and subsidized glasses. These number shows that we have improved the access of eye care in rural areas and raise awareness about the importance of eye care, and made health facilities accessible to the person with disabilities. Thank you very much, and conclude my presentation.
Thank you, Shahid sir. I invite Muhammad Iqbal Javed for his talk on awareness regarding diabetic retinopathy.
Thank you very much, sir. Today, my topic is awareness regarding diabetic retinopathy among general adult population of urban slum areas of Lahore. I am Muhammad Iqbal Javed, working at Teaching Hospital, Gulab Devi, Lahore. As we know, diabetes mellitus type 2, this is a metabolic disorder which the body has high sugar levels of prolonged period of time. Symptoms may include frequent urination, excessive thirst or hunger and weight changes. Causes are when there is inadequate production of insulin or insulin resistance, and treatment may include lifestyle changes such as diet control and medication or insulin. Diabetic retinopathy is a complication, retinal complications by the prolonged duration of diabetes. At first, diabetic retinopathy might cause no symptoms or only mild vision impairment, but it can lead to blindness at all. The condition can develop in anyone who has type 1 or type 2 diabetes. Longer you have diabetes and the less controlled your body sugar is, the more likely you are to develop this eye complication. And here is a relationship among the diabetes mellitus and diabetic retinopathy. If diabetes mellitus persists, diabetic retinopathy exists. And diabetic retinopathy, this is, we know it is complications, and complications are cataract, glaucoma, diabetic retinopathy, visual impairment, and leads to blindness. Methodology of our study, this is a cross-sectional observational study of 6-month duration. 283 total participants were included in the study, and data are collected on self-structure performa and analyzed with SPSS software version 26. Inclusion criteria, all new and follow-up patients were selected for the study with known diabetes mellitus of age 25 years. And patients with retinopathy, glaucoma, cataract, high myopia, hazy ocular media, a history of trauma, and other systemic diseases were excluded from the study. This is the age and gender of the participants. And males were 44% and 164, females 56%, and total participant 375, and the females were dominant group in the study. And knowledge about diabetes mellitus, and this has been shown that a total of 164 males know about diabetes mellitus, that is 53 and 32.31%, and 111, 67% do not know the knowledge about diabetes. And in females, this ratio is 16.11%, and who know about the diabetes mellitus, and 81.99% does not know about the diabetes mellitus. And meanwhile, the diabetic retinopathy knowledge in males, this was 28.04%, and in females, this was 20.37%. And here is the diabetic control, gender-wise, that in males, only 5 control diabetes very strictly, and 49, 5.48% strictly, and not strictly 110. And in females, this was the habit of control diabetes 11, and strictly 80, and not strictly 120. And this is the treatment taken for diabetes, males and females, and mostly the participants using the pills at all. And if you know here that the journal and eye health advice For general physician, for diabetic controls, regular visits was only 28%, and visit to ophthalmologist, this was 48%, 48 and 13% only. And conclusion and recommendations of our study is that awareness campaigns at community level is necessary. Initiation of screening program is very crucial. Effective referral chain protocol, free of cost eye health services due to poverty, multidisciplinary coordination approach in health system and in hospitals, accessible, affordable and sustainable eye health provision for all, training of health professionals to sensitize about the diabetic retinal complications. Thank you. Any question?
Any questions from the audience? Thank you, Iqbal sir. Next talk is by Shahid Maqbool Sahab on modalities for screening and referral in PEAK project.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Shahid Maqbool. I lead PEAK project, College of Ophthalmology and Allied Vein Sciences, May Hospital, Lahore. I will try to explain the modalities for screening and referral for PEAK programs. The goals of the training. ہم جن کینڈرس کو ٹریننگ دیتے ہیں ان میں LHVs, LHWs, SHNS, optometrists ہوتے ہیں. ان کو ٹریننگ کے اینڈ پہ ان تمام ٹاپکس پہ پورا گرپ ہوتی ہے. ٹوٹل 3 days ہوتے ہیں ٹریننگ کے. ان میں سے 2 days ان کی فیلڈ ٹیسٹ ہوتا ہے, جو فیلڈ میں جا کے جو ہم پریکٹیکلی پرفارم کرواتے ہیں ان کو. ٹریننگ ماڈیول فار نیو پیک یوزر, جتنے بھی پیک یوزر جن کی میں نے بات کی ہے ان کا یہ ٹوٹل ٹاپک ہم ان کو ایکسپلین کرتے ہیں, ان کو پڑھائے جاتے ہیں 3 دن کے اندر. پہلا ہے پیک ایکویٹی, دوسرا ہے کیپچر اینڈ ایڈمن. پیک ایکویٹی بیسیکلی ایک اپلیکیشن ہے جو کہ پلے اسٹور کے اوپر اویلیبل ہے, اور ہر بندہ اس کو ڈاؤن لوڈ کر کے اپنے فون پہ کسی بھی بندے کی ویئر ایکویٹی چیک کر سکتا ہے. یہ کام ہم بیسیکلی کرواتے ہیں LHW, LHV اور SHNS کو فار ٹریننگ پرپسز, تاکہ وہ موبائل کو یوز کرنے کے فیملیرائز ہو جائیں اور نیکسٹ پیک کیپچر پہ کام کرتے ہوئے ان کو کسی قسم کی ڈیفیکلٹی نہ رہے. نیکسٹ ہے نان افیکٹو آئی کنڈیشنز. یہ کنڈیشنز LHV کی ڈیفرنٹ ہوتی ہیں, LHW کی ڈیفرنٹ ہوتی ہیں, SHNS کی ڈیفرنٹ ہوتی ہیں, اور یہ پیک کیپچر کے اندر موجود ہوتی ہیں. آپٹومیٹرس چیک کرنے کے بعد ان کو پوائنٹ آؤٹ کرتا ہے اور آگے پیشنٹ کو ریفر کر دیتا ہے. آئی ایگزامینیشن میتھڈ, یہ بھی کام بیسیکلی آپتھلمالوجسٹ کا ہوتا ہے, جو اس کو چیک کرنے کے بعد اس کو ڈائگنوز کرتا ہے اور اس کی میڈیکیشن پرووائڈ کرتا ہے. ورک فلو, رول, رسپانسبلٹی, پیک ڈیوائس, یہ سارا اس کا سیٹ اپ کر کے دیا جاتا ہے. اس کی فردر ایکسپلینیشن نیکسٹ سلائڈس کے اندر موجود ہے. پیک ایکویٹی کا میں آلریڈی ایکسپلین کر چکا ہوں کہ یہ اسمارٹ فون بیسڈ ویل چیک ایپ ہے ڈیولپڈ ٹو allow anyone to check wheel acuity using only on the Android smartphone. We use peak acuity to familiarize the training with the technique before using peak capture. Peak acuity کے اندر بیسیکلی 5 اسٹیپ ہوتے ہیں. ہم چونکہ جس کیڈر کو یہ ٹریننگ دے رہے ہوتے ہیں ان کا ایجوکیشن لیول لو ہوتا ہے, تو ان کو ہم اردو کے اندر ہر چیز ایکسپلین کرنی پڑتی ہے ہمیں. تو ٹوٹل 5 سیٹ پیک ایکویٹی کے یہ بتاتے ہیں کہ اسکریننگ 3 میٹر کے فاصلے پہ کرنی ہے, اسکریننگ ہمیشہ بیٹھ کے کرنی ہوتی ہے, مناسب روشنی پہ اسکریننگ کرنی ہے. چوتھا کہ جب اسکریننگ کر رہے ہوں تو موبائل ٹلڈ نہ ہو, موبائل بالکل اسٹریٹ پکڑیں. ایک 5واں اسٹیپ یہ ہوتا ہے کہ جب موبائل آپ اس نے کلائنٹ کی طرف کیا ہوتا ہے تو وہ موبائل اور کلائنٹ کی آنکھ کا لیول بالکل ایک سیدھ میں اوپر نیچے کرے گا, تو وہ وی این اسی پراپر چیک نہیں کر پائے گا. جب اسکریننگ اسٹارٹ ہوتی ہے پی کیپچر کے اندر تو وہ پہلے کیپچر اس کو کہتا ہے کہ آپ نے رائٹ آئی کی اسکریننگ چیک کرنی ہے. رائٹ آئی کو چیک کرنے کے لیے اس کو لیفٹ آئی کو کلوز کروانا کرتا ہے. کلوز کروانے کے لیے ایک پراپر میتھڈ ہے کہ آپ نے لیفٹ آئی کو چیک کرنے کے لیے لیفٹ آئی پہ ہاتھ رکھوانا ہے, جب رائٹ آئی کو چیک کرنے کے لیے لیفٹ آئی کو کلوز کروانا ہے, جب لیفٹ کا چیک کرنا ہے تو رائٹ آئی کو رائٹ ہینڈ سے کلوز کروانا ہوتا ہے. تو یہ اسٹیپ ان کو اردو میں ایکسپلین کر دیے جاتے ہیں. ہاؤ پیک امپاورڈ دا کمیونٹی پروگرامس, مطلب کہ پیک کیپچر اور پیک کیپچر کے اندر جتنا کام ہوتا ہے وہ سارا کا سارا پیک ایڈمن کے اوپر واچ کیا جا رہا ہوتا ہے. ایک دن کے اندر ایک اسکرینر نے کتنے پیشنٹ اسکرین کیے ہیں, ان میں سے کتنے ریفر ہوئے ہیں, وہ سارا کا سارا ڈاٹا ایڈمن میں کالج پہ بیٹھ کے ہم دیکھ رہے ہوتے ہیں. پیک کیپچر ڈیوائس سیٹ اپ. مطلب جب ہم ان کو ٹریننگ دینے جاتے ہیں تو ٹریننگ موبائل ان کے ہینڈ اوور کرتے ہیں, تو موبائل کے اوپر پیک کیپچر آلریڈی انسٹال کر کے دیا جاتا ہے, اس کے اوپر ان کا اکاؤنٹ رجسٹرڈ ہوتا ہے. اکاؤنٹ رجسٹر ہوگا تو وہ اس کے اندر لاگ ان ہو پائے گا, لاگ ان کر کے وہ فردر آگے پیک کیپچر کے اندر کام کر سکے گا. اس میں انٹروڈکشن ٹو پیک کیپچر اپلیکیشن, ہاؤ ٹو ڈاؤن لوڈ اینڈ انسٹال پیک ایکوٹی. بیسیکلی آپ پلے اسٹور سے ڈاؤن لوڈ کر سکتے ہیں, لیکن پیک کیپچر ایک ایسی اپلیکیشن ہے جو ایک اسپیسیفک ویب سائٹ, دس از directory.peak.vn سے جا کے ڈاؤن لوڈ ہوتی ہے, وہاں سے ڈاؤن لوڈ کر کے اس کو انسٹال کیا جاتا ہے. تو ہر ایک کے پاس اس کے رائٹس نہیں ہوتے ڈاؤن لوڈ کرنے کو, انسٹال کرنے کے. اس کے بعد اکاؤنٹ ریکوائرمنٹ فار پیک یوزر, تو آلریڈی میں ایکسپلین کر چکا ہوں کہ جب انہوں نے پیک کیپچر پہ کام کرنا ہے تو کام کرنے کے لیے ان کو اکاؤنٹ, اس کا لاگ ان پاسورڈ کی ضرورت ہوتی ہے. ہم اس کو آلریڈی یہ چیزیں سیٹ کر کے موبائل ان کے ہینڈ اوور کرتے ہیں. ہاؤ ٹو کیپ فون اپ ڈیٹ اینڈ کیپچر, یہ ساری چیزیں آگے نیکسٹ سلائڈ کے اندر ایکسپلین ہو رہی ہیں. پیک کیپچر کا میں آلریڈی بتا چکا ہوں. اس کے بعد ہے ود دا پیسیج آف ٹائم, پیک کیپچر کے اندر کچھ نہ کچھ انوویشن ہوتی ہے, کوئی اپڈیٹس آتی ہیں, تو وہ پاپ اپ ان کے موبائل کے اوپر آتا ہے, وہ اس پہ کلک کرتے ہیں, آگے انسٹرکشن بھی اندر موجود ہوتی ہیں کہ آپ نے کیا کیا کرنا ہے, تو وہ اپنے موبائل کو ہر ٹائم اپڈیٹ رکھتا ہے. ٹریننگ انوائرمنٹ, لائیو انوائرمنٹ, یہ دونوں چیزیں بیسیکلی کیپچر کی ہیں اور ایڈمن کے اندر بھی موجود ہوتی ہیں. جو ہم 3 دن ٹریننگ دیتے ہیں ان کیڈرز کو, جس میں SHNS ہیں, LHV ہیں, اور اس کے بعد آپ کے جو LHW LHS ہوتی ہیں یا اپٹومیٹس بھی ہوتی ہیں, تو ان کی 3 دن ٹریننگ موڈ میں ہو رہی ہوتی ہے. آخری دن ان کا سارا ڈیٹا لائیو پہ کنورٹ ہوتا ہے, پھر لائیو فیلڈ ٹیسٹ میں جا کے جب کام کرتے ہیں تو وہ لائیو انوائرمنٹ میں کام کر رہے ہوتے ہیں. ڈیوائس ایڈمنسٹریٹر, یعنی اس کو سیکیور کرنے کے لیے ڈاٹا کو, موبائل کو, ہم اس کو ایڈمنسٹریٹر بھی انیبل کرنا ہوتا ہے. اسکرین لاگ, عمومی جو آپ موبائل رکھتے ہیں اس کے اندر پن 4 ڈیجٹ کا ہوتا ہے, لیکن کیپچر کی یہ کے لیے ریکوائرمنٹ ہے کہ آپ کی جو سیکیورٹی ہے وہ 6 ڈیجٹ کی ہو. اگر 4 کی لگائیں گے تو کیپچر اس کے اوپر پراپر کام نہیں کرے گا. تو جو موبائل ہم یوز کیپچر کے لیے کر رہے ہوتے ہیں اس کے اوپر سیکیورٹی 6 ڈیجٹ کی اپلائی کرنی ہوتی ہے. اس کے بعد کیپچر لاگ ان, یعنی انسٹال ہو گیا تو لاگ ان کرنے کے لیے میں نے آلریڈی بتایا کہ ای میل ID پاسورڈ ہوتا ہے, وہ ہم اس کو پٹ کرتے ہیں. اس کے بعد وہ نیچے جی آ رہا ہے رجسٹرڈ نیو یوزر, تو یوزر کو رجسٹر کریں گے تو وہ کام کر پائے گا کیپچر کے اندر. اگر وہ رجسٹرڈ نہیں ہے, انسٹال کر بھی لیا کسی نے ویب سائٹ پہ جا کے, تو وہ کیپچر کے اوپر کام نہیں کر سکتا. ڈیٹا انکرپشن کی فیسلٹی ہوتی ہے. اس کے بعد ڈیٹا ڈیوائس انکرپٹ ہوتی ہے, آلریڈی میں نے بتایا سیکورٹی لگی ہے, اس کے اندر ڈیٹا ہمارا ڈیٹا سارا کا سارا سیکیور ہے. پیک کیپچر ورک فلو, بیسیکلی یہ ایکسپلین کرتا ہے کہ فیلڈ کے اندر جو لوگ اسکریننگ کرتے ہیں تو پیشنٹ جن کو آگے ریفر ہونا تھا وہ کہاں ریفر ہو رہے ہوتے ہیں. تو اسکریننگ کرتے کون ہیں, وہ 3 کیڈر میں نے بتایا, LHVs, LHW, SHN ہوتی ہیں. اب جو اسکریننگ کرے گا تو اس کو یا تو پیشنٹ ہیلدی ملے گا یا وہ ڈسپینس ایڈوائز کرے گا. مطلب اگر وہ ایکسیڈنٹل کیس تھا تو اس کو آگے DH کو ڈاکٹر کے پاس بھیجے گا, نہ کہ وہ آپٹومیٹر کے پاس بھیجے گا. ریفر ٹو دا ٹرائیج, اگر اس کو کسی ریفریکٹر ایرر ہے یعنی گلاسز کا مسئلہ ہے تو وہ RSC کے اوپر جہاں پہ آپٹومیٹر بیٹھی ہوتی ہے وہاں پہ ریفر کرے گا. نیچے آ رہا ہے SMS ریمائنڈر, جب جو پیشنٹ آگے ریفر ہوتے ہیں ان کا ڈیٹا جب پٹ کیا جاتا ہے تو موبائل نمبر دینا مسٹ ہوتا ہے. اگر موبائل نمبر نہیں دیں گے تو ڈیٹا وہ کیپچر آگے موو نہیں کرے گا. موبائل نمبر دینے کا فائدہ یہ ہوتا ہے کہ جو کلائنٹ چیک ہوتا ہے اس کو جو ڈیٹ دی جاتی ہے آگے جانے کے لیے, وہ اس کے موبائل کے اوپر فوراً SMS چلا جاتا ہے کہ آپ کو فلاں BHO پہ چیک کیا گیا ہے, آپ کو فلاں ڈیٹ کے اوپر فلاں RSC کے اوپر جا کے چیک کروانا ہوتا ہے. اسی طرح ٹائیج لیول کے اوپر جب آپٹومیٹس اس کو چیک کرتی ہے, اگر تو گلاسز سے مسئلہ حل ہو جاتا ہے تو وہ ادھر ہی اس کا لوپ کلوز ہو جاتا ہے. اب نیچے دیکھ رہے ہوں گے لوپ کلوز اور نیڈ میڈ, اگر وہ گلاسز کا مسئلہ وہیں لوپ کلوز ہو گیا, آگے جانے کی ضرورت نہیں ہے. اگر آگے جانا ہے تو پھر وہ اس کو آگے THQ DHQ کو ریفر کرتی ہے, وہاں پہ اس کو فردر ڈائگنوز کے لیے جو ہے نا وہ ڈاکٹر کے پاس جانا ہوتا ہے. جو ڈیٹا جتنا بھی آپٹومیٹرز یا اسکرین پہ کام کر رہے ہیں وہ سارا کا سارا ڈیٹا ایڈمن پہ دیکھا جا رہا ہوتا ہے. یہ نان فیکٹر ایرر ہے, یہ ہر کیڈر کی الگ الگ ہوتی ہیں. پہلا LHW یہ 5 چیزیں وہ جسٹ دیکھ سکتی ہے. اسی طرح LHV SHN ان کی آگے یہ والی چیزیں ہیں. اسی طرح NS جو ٹائیج آپٹومیٹرز بیٹھی ہوتی ہے ان کی NRC ڈفرینٹ ہوتی ہے. اسی طرح ڈاکٹر کی NRC کی 2 سلائڈز ہیں, یہ بہت زیادہ ہوتی ہیں. یہ ڈائیگرام ہے, فلو ڈائیگرام, جو بتاتی ہے کہ پیشنٹ اگر پاس ہوگا تو ادھر ہی لوپ کلوز ہوگا, اگر ریفر ہوگا کس وجہ سے ریفر ہوگا تو وہ آگے ٹائیج پہ جائے گا, اگر اس نے NRC کا مسئلہ تو وہ آگے ڈاکٹر کے پاس جائے گا. اسی طرح एट द एंड जब DH के ऊपर पेशेंट चेक हो रहा होता है तो वहाँ पे अगर उसको फैसिलिटी नहीं है, सपोज उसको लेज़र की ज़रूरत है, तो फिर आगे टर्शियरी हॉस्पिटल जाने की फैसिलिटी होती है और वहाँ भी हमने ऑप्टोमेट्रिस्ट को मोबाइल दिया होता है, वहाँ पे कैप्चर इंस्टॉल होता है। ये सारी चीज़ें वही चीज़ एक्सप्लेन हो रही होती हैं। पीक डिवाइस बेस्ट प्रैक्टिस, ऑलरेडी हमें हर एक को पता है कि डिवाइस को हमने सिक्योर कैसे रखना है, उसको प्रोटेक्ट कैसे रखना है, लेकिन हम फिर भी उन लोगों को ये सारी चीज़ें एक्सप्लेन कर रहे होते हैं कि आपने पीक डिवाइस को जो है वो सिक्योर रखना है। अगर कोई डैमेज होता है, कोई मिसहैप हो जाता है, तो उसका एक रूल है, पूरा SOPs बने हुए हैं कि वो अपने डिवाइस को जो ना वो FIR करवाएगी, फिर हमें इन्फॉर्म करेगी विद द परमिशन ऑफ प्रिंसिपल कॉलेज ऑफ ऑप्थेल्मोलॉजी, फिर हम उसको देने के बजाय होते हैं। आगे जितनी बातें मैंने की हैं सारा का सारा डाटा इस एडमन पे शो हो रहा होता है। ये जितने भी आपको सर्कल नज़र आ रहे होते हैं, पहला सर्कल स्क्रीनिंग का लेवल है, दूसरा टाइएज का है, तीसरा जो है ना वो THQ DHQ लेवल था। इसके आगे भी सर्कल होते हैं जो कि स्पेक्टिकल प्रोवाइड करते हैं, उनकी सारी की सारी डिटेल उसके अंदर मौजूद होती है। ये चीज़ें ऑलरेडी मैं एक्सप्लेन कर सकूँ। थैंक यू वेरी मच। एनी क्वेश्चन?
Any questions? Thank you, Shahid sir. Next is a very important talk from Ms. Zeenat Khan on success story of trachoma elimination.
Assalamu alaikum. I am Zeenat Khan from College of Ophthalmology and Allied Sciences. I feel very honored to express the success story of the trachoma elimination in Pakistan. This is the map of Pakistan which show the population of Pakistan and the human resource. Actual story was started from 2001 to 2002 when trachoma rapid assessment in 230 villages across Pakistan was started, and its result was published by International Trachoma Initiative. According to the TRA results, trichomas are found in these areas, and these are the result of the trachoma active, where we find the prevalence of the trachoma very high. This is the time when National Trachoma Task Force was established under the umbrella of the National Committee for Eye Health Pakistan, Ministry of National Health Services Regulation and Coordination. All NGOs, stakeholders working for trachoma and provincial headquarters for blindness control program were its members. These are the partnership. In this period, SAFE strategy was implemented in the high to moderate priority clusters, which is based on the result of TRA. WHO was taken on board. 2006 is the period when WHO advised for the trachoma survey in Pakistan. Now there is the selection of the 39 districts where the population-based methodology of WHO used, and there is the phase-wise work is completed. In first phase, 15 districts was covered, in which 6 districts sponsored by Government of Pakistan and 9 districts sponsored by SightSaver and CBM. In phase 2, 16 districts covered. The financial support was given by the SightSaver. In third phase, 7 districts was covered, and now the funder is the Fred Hallow Foundation. Luckily, it is the era of GTMP when Pakistan was included in 22 country-wide project of the Global Trachoma Mapping Program. Selection of the 8 doctors, 20 optometrists from Pakistan, and training by the international trainer was completed in Nigeria and Tanzania. Priority list of the National Trachoma Task Force for trachoma survey in 15 districts was approved and survey conducted under GTMP guideline. 54 districts have been surveyed till 2016 under National Trachoma Task Force. Mass drug distribution, where TF and TT were both high in previous survey, was conducted with donation from Pfizer International. 2.7 million doses were distributed in Pakistan. The result was published by GTMP. Now the time when the trachoma action plan was developed. It is developed by the National Trachoma Task Force in 2016 and it is updated in 2017 by NTTF. This action plan was approved by National Committee for Eye Health in 2017. Fred Hollow Foundation got grant for Pakistan Trachoma Elimination Project in 2018. Trachoma Elimination Program was awarded to FHF. CBM Sightsaber worked as an implementing partner to do the following work. Survey in 14 districts with TT. 9 international master trainers were trained by CBM trainer at Hyderabad. Implementation of the TT survey project in 6 districts. Surveillance survey in 2 districts where MDA was implemented, both cleared. Implementation of the F&E in the 6 districts. Resurvey in the 6 districts with high TFL. These are the few pictures. The SAFE strategy was implemented in Pakistan, GB, Punjab, Sindh, Balochistan and KPK. This is the pictorial view. To find the more evidence, TRA in the 23 additional priority districts was conducted, satisfactory result published, approved by ITI. Now when we find all the evidence, the briefing is given to WHO in 2021. Pakistan Dossier Committee established in 2021. Consultative workshop with stakeholder held in December 23 and dossier was completed April to January 24. These are the partners of the consultative meeting. It is the climax of the story that Pakistan declared as a trachoma-free country announced by the WHO. And we are, alhamdulillah, we are very blessed to find and got this award. It is the success story of the trachoma elimination in Pakistan. The time is so short to close all the evidence in a very short period. Thank you very much.
Thank you, ma'am. Any questions?
This is a great achievement. When we started ophthalmology in 1978, people of my age group knows that trachoma was so prevalent and almost epidemic, and every single patient, every second patient coming to the OPDs were suffering from some kind of, and there were lots who never visited the hospital and they were suffering from trachoma. It's a great achievement that Pakistan has been declared trachoma free. Thank you.
Thank you, sir. Next, I'll invite Ms. Aisha Sarfraz for her talk on prevalence of disabilities in National RAB Survey.
Bismillah ar-Rahman ar-Rahim. I'm Aisha Sarfraz, working as an orthoptist at College of Ophthalmology and Allied Vision Sciences. And I'm presenting on prevalence of disabilities in National RAB Survey 2022. So this is the lineup. So RAB is Rapid Assessment of Avoidable Blindness. Is a cross-sectional population-based survey standardized for the prevalence and causes of visual impairment and blindness among the population older than 49 years. It had been adapted from Rapid Assessment of Cataract Surgical Services and developed by International Center for Eye Health based in London School of Hygiene and Tropical Medicine and powered by Peak. Since inception, there are multiple versions. In this particular survey, RAB 6 was used and it has a disability module. So it is RAB has been supporting evidence-based eye care planning, services, monitoring and evaluation, and is an important tool in achieving the global eye health priorities set out by the WHO. And it provides the majority of data used to estimate the global and regional prevalence and causes of impairment, as well as data which is vital for tracking progress towards universal health coverage. So the latest version of the RAB is RAB 7, which has been started in 2018 as a collaboration between ICEH and Peak Vision. They have some key features of RAB 7, just for the information. So additional data for inclusion in the rapid assessment are also being tested. These data reflect the needs outlined in Transforming Our World, the 2030 Agenda for Sustainable Development, including dimensions of equity, courage, and quality. So to start with this topic, I would like to introduce the disability. What is disability? And disability is an umbrella term referred to any restriction or lack of the ability to perform an activity in the manner or within the range considered normal for a human being and in a functional consequence of an impairment. So an estimated 15% of the world's population live with a disability, and globally at least 2.2 billion people have a near or distance vision impairment. The functional limitation was classified by International Classification on Functioning Disability and Human as follows: as impairment categories, activity limitation category, and participation restriction category. For this particular survey, the disability module, the Washington Group short set on functioning questionnaire was used. The questions in this particular group reflects advances in the conceptualization of disabilities and use the World Health Organization ICF as conceptual framework. These are the domains of the Washington Group shorts question, which include seeing, hearing, walking, cognitive, self-care, and communicative domains. So these are the categories of limitation in functioning, including no difficulty, some difficulty, a lot of difficulty, and cannot do it all. The objective of this particular presentation is to document the extent of difficulty in functioning in 6 domains of disability. So it's a cross-sectional survey conducted across 15 districts or provinces: Balochistan, Punjab, KPK, and Sindh. Multi-stage cluster random sampling was used. 80 villages per district were selected. 35 people per cluster aged 50 years and above were interviewed, and data on blindness and vision impairment and diabetes in people aged above 50 years were collected. Extent of difficulty, as I already mentioned, was collected by using Washington Group short set on questioning, and ethical approval was gained by the Ethical Review Board of the CUAVS, further approved by NCEH. So there are a few results. So the total sample size was 40,745 people, in which the disability prevalence was found to be 14.4%, with top 4 limitations are in the category of seeing, walking, self-care, and hearing. And the other non-seeing categories prevalence of disability was 7.9% of all the total population, and here we can see that the male population has slightly more prevalence of disability in this particular survey. So we get in non-seeing category, the categories of functioning, including a lot of difficulty and cannot do it all categories, have 11.8% disability in the range of non-seeing categories, and 14.4% in the prevalence of limitation in functioning categories 3 and 4. And visual blindness is the prominent visual impairment category in all 6 domains of disability combined, followed by moderate visual impairment. It also shows that vision care and eye health services are important aspect of providing universal health coverage. So more than 46% of older persons, those aged 60 years and over, have disabilities, and more than 250 million older people experience moderate to severe disability. Looking ahead, the global trends in aging populations and the high risk of disability in older people are likely to lead to further increases in the population affected by disability. The population-wide structural and social determinants of health that generate, sustain, and even widen health inequities are well documented and disproportionately impact persons with disabilities. Persons with disabilities experience health inequities in terms of increased mortality, morbidity, and limitation in functioning when compared to the rest of the population. So we can easily conclude that in 1 in 10 persons aged 50 years and above have limitation in functioning, and a large population in these 6 domains were in the blind category. Visual impairment is a cross-cutting limitation in functioning across all 5 non-seeing domains. Actions are required by all stakeholders to improve health services for persons with disabilities. Any questions? Thank you very much.
Thank you, ma'am. I'll invite Ms. Taiba Burhan for her talk on inclusive eye health.
Bismillahirrahmanirrahim. My name is Taiba Burhan and I am working as orthoptist in Mayo Hospital, Lahore. The topic I am going to present is an approach towards inclusive eye health and screening to compare the frequency of ocular problems of people living in residential colonies and homeless communities in Lahore. So first of all, we need to know that about the population of Lahore and how many people are homeless. Lahore is a city of 14.4 million people in 2023 census. There are more than 185,000 homeless people in Lahore alone. Lahore, like most cityscapes, is a microcosm of a divided society with the haves and have-nots. In residential colonies, living in formal housing, residents have comparatively less difficulty gaining access to health, including an ocular care facility. They are privileged to select standard ocular clinics, set appointments, and get the correct timely treatment for any eye complications. On the other hand, the homeless suffer from several barriers to accessing health care. Operational definitions: inclusive eye health mean guaranteeing eye care services accessible to all community adherents. Homelessness, the state of lacking a stable nighttime residence. So what basically are the group of the marginalized communities which are neglected? Racial or ethnic minorities, transgenders, people with disabilities, immigrant or refugee populations, people living in poverty, homeless, prostitutes, in certain cases, old people as well. Homelessness is linked to a diversity of health snags such as mental health disorders, drug and alcohol misuse, and infectious diseases. Also, instability in homes plus exposure to some environmental conditions augments the health risks of eye infections and injuries. The prevalence of ocular diseases is much worse among people within low and middle income countries, mainly because quality ocular care amenities are lacking. Gender also play a part, which in turn is aggravated by socioeconomic status, meaning that homeless people or people from low income areas are most at risk. High risk areas which were identified were Data Darbar, Minar-e-Pakistan, Chuburji, Shahi Kila, and Bhatti Chowk. This problem of homelessness is accompanied by some other social issues like drug addiction, beggary, theft, and prostitution. It also reflects the increasing inflation rate and shortage of affordable houses. So what are basically barriers towards examination? First of all, financial resources to buy medications and glasses. Secondly, prejudice against which they feel discriminated. Thirdly, unstable addresses and IDs can be an obstacle to their registration. Why they are more prone to the ocular infections? Due to the poor sanitation, hygiene, and poor nutrition. The aim of the study was to find out the proportion of ocular diseases in homeless population in Lahore. So these were the materials used in the study. Exclusion criteria: individuals who are unable to be examined, individuals with severe cognitive impairment or mental health conditions that could prevent them from understanding or participating in the study. Individuals were unable or unwilling to provide informed consent. Inclusion criteria was homeless individuals from age group above 5 years. Sample size: homeless population of 290 people, 145 in each group, homeless and residents. Duration of study: 3 months after synopsis approval. This was the formula, and a proportional cross-sectional study was accomplished. This is basically the look of the performa I used for screening, for checking the different ocular problems. Ethical consideration. This study was done after ethical authorization from college, and informed consent was gained from each person while taking their images. For screening purposes, use of face shields, masks, and sanitizers was maintained. So this is how these types of areas look like, and you can see the poor sanitation and hygienic conditions, which is the basic cause of the ocular infections. This is one of the workshops I attended on inclusiveness. Results of the study. Interestingly, a great proportion of individuals in the residential group, 63 out of 145 had no ocular problem compared to the homeless group. This is the bar graph showing the prevalence of the diseases in ocular diseases in homeless and residential people. The table displays the prevalence of various ocular problems among homeless individuals and residents of residential colonies in Lahore. Refractive error was the most common condition overall, but it was more prevalent in residential colonies compared to the homeless population. Conversely, cataracts were significantly more common among the homeless than residents. A similar pattern was observed for lens changes with a higher incidence in the homeless group. Interestingly, a great proportion of individuals in residential colonies had no ocular problems compared to homeless group. So there you can see refractive error was most common condition in both groups, affecting 69 individuals. A striking difference was observed in the prevalence of cataracts with a much higher proportion among homeless people. While other conditions like glaucoma, conjunctivitis, and squint were present, their prevalence was relatively low in both groups. Conclusion, this study found that there is a substantial difference in ocular health between homeless people and residents of residential colonies in Lahore. Homeless people have significantly higher burden of eye diseases and conjunctivitis, with a 10-fold greater likelihood of cataracts and a more than 20-fold higher recurrence of lens alterations. Limitations of the study, it should be accompanied with a medical doctor. Small number of group was addressed, could not explain the severity of the ocular diseases. Recommendations, capacity building, inclusion workshops, and added the curriculum, quarterly or annual screening in the form of eye camps, counseling and referral to teaching hospitals in cases of complicated eye diseases and management. These are the different models in other countries. This was the look of the consent form. This is the basically take-home message from my study. Equality is leaving the door open for everyone who has the means to approach it. Equity is ensuring there is a pathway to that door for those who need it. Thank you very much.
Any questions? Thank you, Ms. Taiba. Next talk is on integrating artificial intelligence in teleophthalmology by Ms. Fatma Zahra.
Assalamu alaikum everybody, I'm Fatma Zahra and I just graduated from Al Khan University. I will be presenting on the topic integration AI, teleophthalmology in rural areas of Pakistan, and I'll be representing on behalf of Dr. Zubaida Sarang. There are no financial interests to disclose. So artificial intelligence in ophthalmology, I feel this is very relevant to talk in this time where we're talking about AI within medicine, so ophthalmology should not be left behind. AI in ophthalmology uses machine learning to analyze eye imaging, early diagnoses, and treatment of diseases like diabetic retinopathy, AMD, and glaucoma, improving accuracy and access to care. So this is something very important I would like to talk about, which is hub and spoke model, which we have been running in the north in Gilgit. So basically what happens is, and since we're talking about community medicine and ophthalmology, this is very relevant because what happens is there's a hub, which is the center. And for AQ, we have a super hub, which is Al Khan Hospital in Karachi. Then we have a hub where we have ophthalmologists sitting who are checking patients. And then we have spokes, which are, so for now we have 2 spokes, which are centers where people initially come for screening. We don't have ophthalmologists there yet, but then we do the screening there, and then whoever requires urgent care is then brought to the hub. So centralizes advanced healthcare services at the central hub while providing basic care through peripheral spokes. That's the model. And now we talk about, so this is just an image to show you how it basically works. Community-based health workers including community midwives. This is a picture of the model which can then be applied to ophthalmology. They then go to the basic health centers, medical centers, and then finally Aga Khan Hospital in Karachi. That's how they are referred. So now, why is there a need for AI integration within this model? Firstly, we need to realize that the rural communities, they do need an increased workforce, or we need to bridge this gap through AI technology. Secondly, clinical triages or assessments require to integrate AI through DLS. Thirdly, infrastructure, AI models, and finance. So this can reduce the burden on our infrastructure right now, how much cost there is to hire people, how we can cover that. And then lastly, collaboration with global AI platforms in ophthalmology, which is very important for research and data collection. AI for diabetic retinopathy screening. So these are a few things that are being used worldwide that we can integrate right now. It's not being done in Pakistan currently, but Google's DeepMind and IDXDR, which is using retinal images from portable fundus cameras. Then primary healthcare workers in rural clinics can screen patients for diabetic retinopathy. And what is the impact we're getting? The impact is early detection of diabetic retinopathy, which will reduce vision loss and burden on tertiary care hospitals. So this is just to show you, this is just an image to show how it's working. For cataract detection via smartphones, one of the speakers just talked about peak vision and how it's used and how easy it is to use. So peak vision can be used. AI algorithms can assess cataract severity and prioritize surgical cases, since we already have a very high burden of disease. And its impact is definitely early detection and efficient identification, which will prevent the leading cause of blindness in rural areas. This is just an image of Peak Vision, which is the app. This is, if you visit their website, this is what you will see, and you can easily download it on your smartphones. So tele-ophthalmology with AI integration. Using platforms like Aravind Eye Care's AI-based screening, rural health workers can capture and upload retinal images. The AI pre-screens the images, and the only flagged cases are then referred to the ophthalmologist. So this reduces patient travel time, financial burden, and ensures that the specialists focus on high-risk cases. AI for resource allocation. So predictive AI models analyze regional data to identify areas where highest burden of eye disease is, and then that enables targeted outreach programs and mobile clinics so that all the resources are spent where they're needed the most. And the impact is that it optimizes resources distribution for maximum impact. Thank you.
Any questions? Thank you, Ms. Fatma. Our last speaker is Mr. Tahir Shokat, if he is present. I think he is not present.
Thank you very much, everybody. Before we conclude the session, I just have one remark regarding the paper of Mr. Rizwan, who spoke about glasses. It's an awareness which is most probably required, because it is still a big stigma that wearing glasses, particularly for ladies and for the cosmetic reasons, and even male, in rural area wearing glasses, they think it's a big stigma, and you know that people don't just wear it, and leads to severe problems like amblyopia and all. And I think a mass aggressive awareness program is needed for that. Now I hand over to Professor Sohail Sarwar to give his concluding remarks about this session. Thank you.
Thank you, Dr. Qamar Islam Lodi. I am talking on behalf of him because he has to summarize, but he has given this talk to me. This was a huge symposium. 11 speakers were here to talk about the community ophthalmology. And all of them are well prepared, and they displayed their work very well, and with the help of infographics that was really appreciable. Mr. Rizwan talked about the role of the CBM in Pakistan. In Pakistan, the community ophthalmology is being done from the place which is College of Ophthalmology and Allied Vision Sciences, which was started by Professor Asad Aslam Khan, and then followed by myself, then Professor Zahid Kamal, and now Dr. Moeen is leading this talk, this task. And the second speaker is our guest from Australia, Mr. Hughes Taylor, and he has very elaborately highlighted the global eye health and the problems of the global eye health with very beautiful graphical presentation. Thank you. We welcome Mr. Taylor here in Pakistan. Enjoy your nice trip here. Then Mr. Shuja, he highlighted on the presentation of, yes, very important topic, keratoconjunctivitis. And I have seen such type of community work first time on this topic. And thank you, Dr. Shuja, for highlighting this subject as far as community work is concerned. Mr. Shahid Sohail, he highlighted that what are the eye care access, and he not only highlighted that how the people they have been educated, he highlighted the problems with the healthcare provider. The healthcare provider should also be trained to deliver all their tasks to the community. So the teaching of healthcare provider is also important. Mr. Javed Iqbal about diabetic retinopathy, very much important disease, and I personally think in diabetic retinopathy the role of calcium dobisalate is very important, and it is 2024 and till now about 72 papers, international papers are published on the role of calcium dobisalate, which we call as tablet capsule doxium, in the role of diabetic retinopathy. And we ophthalmologists, they are very less known about this very common available drug. Shahid Makbul talked about the peak gadgets. It's very important in the screening procedure, and I have already visited his work in the field and how it was effective. I was really amazed, and it gives a very accurate results. Ms. Zeenat Khan, he talked about the elimination of the trachoma. Actually, globally, 4 countries they were left where the trachoma was very difficult to tackle. One was the Pakistan, second is the India, third is the Afghanistan, and the fourth one was the Sudan. And among these 4, we are Pakistani. We are lucky enough to lead all these 4 persons to eliminate in our country. And we are happy that we have finished and declared trachoma elimination 3 days before the Independence Day of Pakistan. Aisha Sarfraz talked about the RAB and avoidable blindness, rapid assessment of avoidable blindness, and one of his slides was very interesting, and he has used probably the JavaScript. I don't know she knows the JavaScript language to produce that graph. Ms. Tayyiba Burhan. Yes, homeless person in Pakistan, very important part of the population which has to be addressed, and there is no data available on the Nadra side of these persons. So these must be addressed and should not be ignored. Last speaker, the topic was presented by Dr. Fatima Zahra, AI. AI is taking place in medicine. Don't be afraid of AI. AI has its own place. There is healthcare, allied health professionals, and there are consultants. AI is making a place in between them. So it will not disturb the allied health professions' place. It will not disturb the place of the consultants. It is in between them, and let it come, and we will be beneficial, and we are ready to accommodate this technology in our ophthalmology practice. Last of all, I thank you all the speakers to highlight us about this topic, and thank you very much for coming and attending this symposium.
All the speakers are requested to collect their certificates from the registration room. Thank you.
May I request all the audience to come on the stage, and we will have a group photo here.